Dear colleagues, dear distinguished lecturers, it's my pleasure to welcome you to the webinars for pediatricians on hypertension in children and adolescents, organized by HyperChildNET COST Action and the European Academy of Paediatrics. I'm Serap Erdine, Professor of Cardiology in the University of Istanbul, Turkey, President of Turkish Society of Hypertension and Atherosclerosis, former Vice President of the European Society of Hypertension, and the Chair of Working Group 5 of HyperChildNET COST Action. Before starting our webinar, I would like to extend my thanks and my congratulations to Professor Empar Lurbe, Chair of HyperChildNET COST Action, for her initiative in the HyperChildNET COST Action, which has started 3 years ago and which will terminate at the end of this year. So, what is HyperChildNET? Please, next. HyperChildNET is a network for blood pressure research in children and adolescents, and the COST Action HyperChildNET is aimed at establishing a European sustainable and multidisciplinary network of internationally researchers, clinicians, early career investigators, health economists, decision makers, patients, regulatory bodies, nutrition and pharma companies, and medical devices manufacturers, focusing on acquiring a holistic understanding of the factors affecting high blood pressure in children and adolescents in order to propose and implement corrective and preventive actions both globally and locally. All members of the network and the research projects running locally collaborate by creating 5 working groups to coordinate research actions, exchange scientific and clinical knowledge, research findings, and best practices. In order to promote the research objectives foreseen, HyperChildNET has organized conferences, seminars, short-term scientific missions, training schools, and produced reports, studies, guides, strategy documents, and action plans. For the first time in HyperChildNET, a large-scale and long-term network of researchers has coordinated and monitored their ongoing research actions on high blood pressure in children and adolescents. And there are 5 working groups: devices, reference values, impact, prevention, and dissemination, and all has worked in close collaboration. One of the most important activities of HyperChildNET COST Action was to prepare a joint statement with European Academy of Paediatrics as a synergistic action between HyperChildNET and the European Academy of Paediatrics, and it was published in Frontiers of Pediatrics, the official journal of the European Academy of Paediatrics. And my special thanks go to Professor Arthur Mazur and also to all the authors, co-authors of the joint statement for assessing and managing high blood pressure in children and adolescents. And today, we have distinguished lecturers, Giuseppe Mancia, Augustina Jankauskienė Mieczysław Litwin, Małgorzata Wójcik, Elke Wühl, Tomas, Seeman, and Manish Sinha together. And now, I would like to invite Professor Giuseppe Mancia for his lecture, the ESH, the European Society of Hypertension, New Adult Guidelines in 2023. Although there is no need to introduce Professor Giuseppe Mancia, he is an emeritus professor of University of Milan Bicocca. He has been the past president of the European Society of Hypertension and the chair of the European Society of Hypertension Guidelines for the Management of Hypertension, and he is very well known for his research activities in the field of hypertension. So he is a mentor, not only for myself, but also for my colleagues. So now we are pleased to listen to Professor Giuseppe Mancia.
Ladies and gentlemen, distinguished colleagues, first of all, let me thank the organizer for the kind invitation to speak on the recent guidelines of the European Society of Hypertension. Now, these guidelines include several novel recommendations, but also an update of old recommendation, or even confirmation and strengthening of previous recommendations. And I'm going to give you some example of all these different aspects of the guidelines. First of all, the guidelines continue to be faithful to at least three important principles which have been observed in all previous European guidelines. That is, guidelines have an educational value, and this means that we have to include in the guidelines an explanation of the rationale and the basis of any given recommendation. Then guidelines should not be prescriptive or coercive. They are based on general types of data, and what has to be done in individuals can differ from the general recommendations of the guidelines. And then, as far as the importance of evidence is concerned, outcome-based randomized clinical trials are the main source of important information, but not the only source, because they also have important limitations. And so guidelines made use of several other types of evidence, such as, for example, post-hoc analysis of trials, observational studies, real-life studies, and even sometimes mechanistic type of data. Let me give you an example of some of the changes. Now, the 223 guidelines used the class and level of recommendations of the previous guidelines, but they also added what we can call the trial quality. That is a number of aspects of the trial which can give an idea of how good is the trial, because we can have a trial with an excellent design, but limited in terms of number of variables measure of accuracy of the measurements. Then there are a number of new cardiovascular risk factors which physicians should know. Now, guidelines support use of the score and score for the elderly, which has been developed by epidemiological data from European countries. But this is based on very small number of variables. And the doctors have to know much more of their patient. And you can see a list of new novelties, which the doctor should know by inquiring with the patient. Some of them unthinkable in the past, such as, for example, non-alcoholic fatty liver, as something which has to do with cardiovascular risk, of chronic inflammatory diseases, environmental factors, migration, and so forth. Then guidelines confirm and strengthen the importance of using organ damage to quantify cardiovascular risk, subclinical organ damage, because organ damage is a major factor for quantification of cardiovascular risk, particularly in hypertensive patients, in which individuals can have subclinical organ damage in the middle age in more than 40% of the patients. And you can see that they can have organ damage even when blood pressure is not elevated or only mildly elevated and other risk factors are not present. So inquirement and search of organ damage is especially important in the stratification of cardiovascular risk of hypertensive patients. But then guidelines add to this a thorough description of the type of organ damage which can be considered, and the characteristics of the measures of organ damage, such as, for example, the reproducibility and operator independence of the data, time to changes, that is, whether one can see the change after a few days or after a few months, in which case, of course, it's useless to repeat the measurement on the short term. And then what is important, they give an idea of how many types of organ damage have evidence that their changes by treatment is associated with patient's prognosis. That is, whether an improvement of organ damage is associated with a reduction of cardiovascular morbidity and mortality. And this is, of course, important for the follow-up of the patient. One other important point is that the guidelines take a very clear status, a very clear role on which is the blood pressure which should be regarded as the reference blood pressure. And there is no question that office blood pressure is the important blood pressure on which to base the diagnosis and treatment of hypertension. And they give a number of recommendations on how to correctly measure office and also home blood pressure. Because one of the current problem in the hypertension area is lack of standardization and lack of accuracy in blood pressure measurement with serious adverse consequences for diagnosis and treatment of hypertension. So office blood pressure is regarded as the main blood pressure, the reference blood pressure, because all the data we have, epidemiological data, but in particular treatment data, they are based on office blood pressure. There are no trials using home or ambulatory blood pressure. This does not mean that home and ambulatory blood pressure are not considered important. In fact, they can be the source of much information. And for this reason, guidelines recommend to go to out-of-office blood pressure measurements, either home or ambulatory, or if it is possible, both home and ambulatory, anytime this is feasible because of the environmental condition or because the healthcare facilities. Indeed, they include the guidelines, an old table which had been included in previous guidelines and also in the American guidelines with the corresponding values between office blood pressure and ambulatory or home blood pressure. But they add an element of caution in interpretation of these data because you have to consider that office and out-of-office blood pressure have a very limited relationship. Relationship is significant, but the correlation coefficient between office and ambulatory blood pressure, well, is of the order of 0.4 or even less than 0.4 correlation coefficients, which means that in individual values, the corresponding value between office and ambulatory blood pressure can be very different from the average correspondent values. This is a study submitted which shows the data from the Phyllis and the ELSA trial in the baseline, 1 year of treatment, 2 years of treatment, or 3 years of treatment in quite a large number of patients. You can also see, and this adds to the caution suggested by the guidelines, that the relationship between office and ambulatory blood pressure can be different in absence of treatment, the dashed line, and during the different years of treatment. So consider the correspondent values, yes, but be careful that in individual patients, the correspondent values can be different from the average ones. Now, threshold blood pressure, that is the blood pressure at which to start antihypertensive drug treatment. The concept of the guidelines is that they should be the office blood pressure values in trials for recruiting patients, in trials which have shown the favorable effect, the protective effect of reducing office blood pressure. And in most trials, if not all trials, these values have been a systolic above 140 millimeter of mercury or a diastolic above 90 millimeter of mercury. And above these values, guidelines recommend to start the treatment not only by lifestyle interventions, if these interventions are necessary, but also by giving drugs. Only one exception is patients with a very small increase in blood pressure above 140 millimeter of mercury and a very low risk. And in this case, physicians may try to limit treatment to lifestyle changes. But if after 3 months, blood pressure control is not achieved, physicians should give antihypertensive drugs. Target blood pressure have been changed in the previous guidelines, less than 130/80 millimeter of mercury. Now, in the current guidelines, patients aged below 64 years should go with treatment below 130/80 millimeter of mercury. But in older patients, guidelines suggest the 2 different targets can be considered. One is to go to less than 140/80 millimeter of mercury. This is a must target because at this level, there is already a substantial reduction of cardiovascular events. But if treatment is well tolerated, even in older patients, physicians should try to go below 130/80 millimeter of mercury. And then what the guidelines recommend is not to actively try to reduce blood pressure below 120/70 millimeter of mercury, because at these low values, well, whether there is an additional benefit is uncertain, but certainly there is an increased number of side effects, and possibly in some patients also an increased risk of cardiovascular events, the so-called J curve. Now, what is said by the guidelines is also that these thresholds and targets are valid in general for the hypertensive population, but not in all subgroups. And here you have a list of conditions in which threshold and targets are different from those I described to you before. Very old patients, patients with isolated systolic hypertension, frail patients, patients with some types of organ damage, patients with coronary disease in which threshold is lower than 140 millimeter of mercury. And then we have pregnancy, children and adolescents in which the criteria for drug treatment are different from those of the general hypertensive population. How should we treat our hypertensive patients? Well, first of all patients may need changes in lifestyle if some of the lifestyles are not appropriate. Now, the lifestyle changes are more or less those recommended in the past, but some new lifestyle changes are recommended by the current guidelines. For example, maneuver the reduced stress, also reducing exposure to noise and air pollution. And then they are more accurate in describing the classical lifestyle measures, particularly with regard to potassium intake, which is upgraded by the current guidelines. How about drugs? Well, the guidelines based their choice on an important concept. That is that the protective effect of antihypertensive treatment is largely due to blood pressure lowering per se, regardless how it is obtained. And there is strong evidence for this. Now, this carries a consequence. That is that the greater is the number of antihypertensive drugs, valid antihypertensive drugs, the greater is the chance of achieving blood pressure control. And in order to decide which drugs should be considered as major antihypertensive drugs, well, guidelines based the judgment on 3 criteria: effective blood pressure reduction, evidence of cardiovascular protection against the placebo in trials, and similar or only slightly different reduction of cardiovascular risk in comparison randomized trials. And based on this, they consider 5 drug classes as major antihypertensive drugs: diuretics, and this is the case for thiazide, but also thiazide-like diuretics like chlortalidone or indapamide, ACE inhibitors, angiotensin receptor antagonists, calcium channel blockers, and this is new compared to several other guidelines, beta blockers, because they do have the same evidence of the other drugs. Of course, one can make use of additional drugs if this is necessary, but this is a second-use drug, not first-use drug. And also mention is made in specific conditions such as kidney disease or resistant hypertension, or new agents such as ARNI, SGLT2 drugs, and non-steroidal mineralocorticoid receptor antagonist. They lower blood pressure, and there is evidence also that they add to the cardiovascular protection of lowering blood pressure in a number of specific conditions. Which is the treatment strategy favored by the new guidelines? Now, first of all, the guidelines devote a section to discussing different strategies. And they recommend or consider the possibility of using the polypill with or without aspirin, therefore, either in primary and in secondary prevention, because now there is evidence from randomized trials that polypill with antihypertensive drugs, lipid-lowering drug, and aspirin, or without aspirin, lower blood pressure and cardiovascular risk. And then there is also evidence that renal denervation can lower blood pressure in resistant hypertension. And so this option can be considered if all other types of treatment, other antihypertensive drugs fail to control blood pressure. But there is no question that the strong recommendation for the general hypertensive population is to use combination treatment. And not in the step care approach, that is starting monotherapy and moving to combination treatment later, but using combination treatment of two drugs as the initial treatment height, hopefully as a single pill combination of the two drugs. Now, the reason for this, and this is a confirmation or a strengthening of previous recommendation, is that unfortunately, if patients start treatment with one drug, then because of clinical inertia and poor adherence to treatment, monotherapy remains the prevailing treatment strategy, as you can see from this slide, which is taken from different countries. And monotherapy is not sufficient to control blood pressure. Controlling blood pressure with two drugs is fundamental for increasing the efficacy of antihypertensive treatment and blood pressure control to almost 90% of the hypertensive population. In the last 5 years, initial use of two drug single pill combination has been shown to have a number of advantages: reduction of treatment inertia, improvement adherence, increased use of combination treatment, reduce of treatment discontinuation, better long-term blood pressure control, and even in a number of large-scale observational studies, reduction in the risk of cardiovascular events. And this is the algorithm. As you can see, treatment should start with two drugs, moving to 3 drugs if 2 drugs are not sufficient to control blood pressure, and achieving, if treatment strategy is correct, 90% of control of the hypertensive population. And you can see that all 5 drug classes can be used, including beta blockers, in combination with other drugs. Now, this is important because it's another element of novelty of the guidelines. That is, several combinations of 2 drugs can be used. Combination between the 5 drug classes, except the combination of ACE inhibitor and angiotensin receptor antagonist, can all be used in the combination treatment strategy. And you can see here that we now have at least 9 different 2-drug single pill combination which can be used for the treatment of hypertension. Finally, an important new aspect of the guidelines is that guidelines this time, they add description and recommendations of hypertension in conjunction with a large number of comorbidities, including young patients, including children and adolescents. Because these conditions, comorbidities, can change not only the threshold and target for treatment, but also the type of treatment and the type of follow-up which patients need. And the guidelines do devote quite a long space to follow up at variance from previous guidelines, describing what should be done by physicians in the initiation follow-up phase, in the short-term follow-up, and in the long-term follow-up, as far as the number of visits is concerned, repetition of the examination, even instrumental examination, adjustment of treatment, and so on and so forth. One of the problems of this important area of guidelines is that very few studies are available, at least controlled studies. But there is no question that doctors need to know what they should be done during the follow-up. And follow-up is a crucial aspect of hypertension treatment. Without a good follow-up, it is difficult to predict a large-scale blood pressure control. And to complete the picture, the guidelines also devote a space to new possible follow-up treatment strategies, such as, for example, use of telemedicine or telehealth technologies, role of pharmacies and team-based care, hypertension clinic, patients organizations, and so forth. And I hope that in the future, this very important aspect of follow-up and in general of blood pressure control of the hypertensive population will be given more and more emphasis, because only through an improvement to this aspect we can hope to remove blood pressure from the undesired position as being, even today, the first cause of death around the world. Thank you very much for your kind attention.
We thank Professor Giuseppe Mancia for his excellent presentation, as always. We are going to have the questions and answers at the end of all the lecturers, and you can either ask your questions via the chat box or either join. Because the session is being recorded, you can easily join and ask your questions. But one thing I have to mention, that you have to mention to whom your questions are addressed to. So now it's my pleasure to invite Professor Augustina Jankauskienė, pediatric nephrologist with wide international collaboration, and she's HyperChildNET member also. Her main interests are chronic kidney disease, arterial hypertension, and she's currently professor at Vilnius University, Lithuania, and as well the head of Pediatric Center of Vilnius University Hospital, Santaros Clinics. In 2023, she was the president of 55th European Pediatric Nephrology Conference in Vilnius. And for her presentation, please, Augustina, on initial workup of the hypertensive child.
And thank you, Serap, for a very kind presentation. And so, dear colleagues, so next slide. So current recommendations regarding the utility of diagnostic investigation for pediatric hypertension are still based on limited evidence, leading to wide practice variation. Next slide. And many societies, famous societies like European Society of Hypertension in 2016 issued guidelines for the management of high blood pressure in children and adolescents. Later, it was followed by American Academy of Paediatrics, and just recently, European Society of Cardiology as well issued guidelines in hypertension in children and adolescents. And as well, our network of HyperChildNET, together with European Academy of Paediatrics, made joint statement on hypertension in children. Next slide, please. So from where to start? So the first questions we have to answer is the patient truly hypertensive in non-medical setting? And then this preliminary, we have to think about initial screening for potential etiology, if it is primary or secondary, and also having in mind age, wave, life history and family history, which might give at the beginning some hints what would be the road of investigation of our patients. So the next, please. So in order to start all the process, first of all, we have to confirm that the diagnosis is done on multiple readings taken at various times and of course properly, and that we have excluded white coat hypertension, and that hypertension is sustained, that it needs further investigation. Next slide, please. So everything starts from the patient's history, and as it was just published in Frontiers in Pediatrics about the assessment in patient history, we have to start from the prenatal history. So it's very important the cause of mother's pregnancy and possible complications, results of fetal ultrasound, birth weight, gestational age, and type of birth. But then going on postnatal history, it's very important to have in mind if the patient or just the child was treated in neonatal intensive care unit, what was the mode of feeding in infancy, what are the anthropometric variables, medical history on use on medications, which sometimes in pediatrics we see it's not so important, but really it is, and also the use of performance-enhancing drugs, smoking, obstructive sleep apnea, lifestyle, including diet and physical activity. And going on family history, we have to have information about both parents, grandparents, and siblings, mostly concentrating on cardiovascular diseasing, cerebrovascular diseases, obesity, type 2 diabetes, chronic kidney disease, and some hereditary endocrine diseases. Next, please. Everything starts from physical examination, so just basic things must be taken in mind. So anthropometrical, so the patient's height, waist circumference, and then of course body mass index, and putting the main stress on cardiovascular status, like pulse, blood pressure on arms and legs, and pulse on lower limbs. And generally physical status, even the general appearance, like can give some sign of syndromic appearance, some skin changes like acanthosis nigricans, coffee or lait, also is very evident about other kind of the diseases, like also examination of abdominal, genitalia, and neurological symptoms. Please, next. I want to share just data which was published by Bonita Faulkner in 2006 about a large group, nearly 19,000 children from 2 to 19 years of age, and very evidently it is seen here that with the age, prevalence of high blood pressure increases as well as it is increased with body mass index, and despite what is the gender, so both in females and in males, so going up. Next slide, please. Recently, Stella Stabuli just overlooked the recommendations of different societies on the initial diagnostic evaluation of children with hypertension. And on some points, most all are agreeing, like on the chemistry panel, some such as electrolytes and kidney function, urine analysis, but already from the kidney ultrasound, it is a little bit different attitude on American Academy of Paediatrics, which is stating that it also only needed for children who are less than 6 years of age or the abnormal kidney function. And lipid profile as well, everyone agrees that it's important, but again, about fasting glucose, again, American Academy of Paediatrics states that it is only at risk for the children with diabetes. More is on echocardiography when it has to be done. And for example, the European Society of Hypertension states that all children with hypertension need at diagnosis need to have echocardiography to be performed. Though Americans just say that all children with hypertension in initiation of pharmacological treatment only. Less is on retinal examination, and that mostly it is going for symptomatic children. But what is important to emphasize here, that mostly all these statements are not graded, so it means that there is not so strict recommendation. Next slide, please. Our HyperChildNet just states about laboratory tests, kind of putting in 2 steps. So just for all children and adolescents with elevated blood pressure, we have to make baseline evaluation. So including, as it was mentioned, kidney function, blood gas analysis, serum uric acid, thyroid hormones, renal and abdominal ultrasound. And just for children who are having stage 2 hypertension, or just less than 10 years of age, or have suspected secondary or monogenic hypertension, then are expected to do more sophisticated assessment like renin and aldosterone concentrations, steroid hormone metabolism, molecular investigation when suspecting monogenic hypertension, and then renal Doppler ultrasound. Next slide, please. It's interesting data just recently published by a Canadian group, which had 128 children from 1 to 18 years of age who were referred to a hypertensive center already with suspicion of arterial hypertension diagnosis. And the authors here state that the most important diagnostic testing in children with hypertension is kidney ultrasound. It's like the first line investigation, because according to the percentage of or number of the tests done from from 128 patients, 106 were done. So the contributory findings were nearly 20% because of kidney ultrasound. So it is stressed that kidney ultrasound is very important, though others might seem of a high percentage, but they were done in just about 15% of so especially picked up population. Next slide, please. And just finishing my short talk, it is important to go to the main points, and it's that prenatal history is very important. Age and weight dynamics, physical examination hinting to some syndromic appearance, and of course we have to think about rational tests with economical balance. Next slide, please. And I'm happy to share blood pressure calculators for pediatricians, which are generated by our HyperChildNET COST Action. And next slide. Thank you for your attention.
Thank you very much. Thank you very much, Augustina, for your outstanding presentation. Now I would like to invite Professor Mieczysław Litwin for the initial workup of the hypertensive child presentation. Professor Litwin is a pediatrician, adult and pediatric nephrologist and hypertension specialist. He is the chief of Department of Nephrology, Kidney Transplantation and Arterial Hypertension at the Children's Memorial Health Institute in Warsaw, Poland, and president-elect of Polish Society of Arterial Hypertension. For several decades, he has been involved in research on the pathogenesis of hypertension and hypertensive vascular damage. As part of the HyperChildNet project, he is the leader of Work Package 3, the aim of which is to develop principles for the diagnosis of hypertensive organ damage in children and adolescents. Mietek, please.
Thank you, Serap, for kind introduction. First of all, I would like to thank organizers for inviting me to this webinar. My task is to describe shortly principles of assessment of hypertension-mediated organ damage. As you may see on this diagram, evaluation of etiology and organ damage is the most important part in management of first approach to hypertensive child. Next, please. What it is hypertension-mediated organ damage? It is structural or functional alteration of arteries and organs such as heart, central nervous system, all vascular beds, including large arteries, microvascular circulation, and kidneys, and caused by elevated blood pressure. So we can say that hypertension-mediated organ damage is a marker of subclinical cardiovascular disease, and it may develop already in childhood. Some forms of hypertension-mediated organ damage are reversible with antihypertensive treatment. However, if hypertension is long-standing and very high, so exposure to high blood pressure and associated immunometabolics, please go back, and is associated with immunometabolic abnormalities. It causes irreversible damage despite neurotension. What are the markers of target organ damage in hypertension? First of all, it is left ventricular hypertrophy and its dysfunction, both systolic or diastolic. Next, there is injury to large arteries, which may cause arterial stiffening, and we can assess it by calculate pulse wave velocity. Subclinical hypertensive arterial injury, also called hypertensive arteriopathy, is assessed as increased intima media complex, most commonly assessed on carotid arteries. And we can assess also target organ damage in hypertension by looking into microcirculation and to look for remodeling and verification of microcirculation. So it is done by using ophthalmoscopy and other ophthalmological techniques. Next one, please. It is a table from our guidelines published a few years ago, and as you can see, the most important marker of hypertension-mediated organ damage is left ventricular hypertrophy, and we can strict criteria how to define left ventricular hypertrophy in children and adolescents. Other markers, already mentioned, of other markers of target organ damage in hypertension is arteriopathy, which can be assessed as carotid intima media thickness and arterial stiffness assessed as pulse velocity, and we can also use referential values for age and sex. We can also assess kidney damage using such markers as proteinuria or albuminuria, and it seems that to assess proteinuria is a better marker in children and adolescents. Next one, please. Here you see the table from adult guidelines on hypertension just published last year. And as you see, there are strict criteria to define left ventricular hypertrophy and remodeling of left ventricle using relative wall thickness. There are also strict criteria to define increased arterial stiffness using carotid femoral pulse velocity. However, what is important? This method is useful for older adults, not for all, and also to strict criteria to define increased intima media thickness. However, as you see, it is called as carotid atherosclerosis. It is because assessment of intima media thickness in adults differs slightly from the technique of assessment of intima media thickness in children. And the other marker of hypertension-mediated organ damage recommended by guidelines is assessment of microcirculation by ophthalmoscopy. However, as you see, ophthalmoscopy, classic ophthalmoscopy is useful only in severe cases of hypertension. Next one, please. In this joint statement, we tried to grade methods of assessment of hypertension-mediated organ damage. And as you see, the most important marker is assessment of left ventricular hypertrophy by echocardiography. Electrocardiography, still used, is not recommended as a tool for assessment of left ventricular hypertrophy. However, it has its place in general assessment of the hypertensive child. The other marker is measurement of carotid intima media thickness and carotid femoral pulsar velocity. These techniques are not obligatory. However, if feasible, we recommend to use it as a second technique to assess hypertension-mediated organ damage. What is important? Both carotid intima media thickness and pulsar velocity are markers which change with age. So results should be interpreted in relation to appropriate referential values. And we have such values both for CIMT or pulsar velocity in children from 6 to 20 years. And as already discussed, ophthalmoscopy is not obligatory at the first diagnostic step. However, in case of severe hypertension, it is a very useful tool in further therapeutic decisions. We still know not too much about usefulness of albumin-creatinine ratio as a marker of kidney damage. However, it is an additional tool for assessment of kidney damage. Next one, please. Left ventricular hypertrophy in children is defined quite well. What is important in younger children up to 9 years, we should base on percentile values. And left ventricular hypertrophy is defined as left ventricular mass index above 95th percentile. In the age range of 9 to 15 years, there are strict cutoffs to define left ventricular hypertrophy. And as you see, it is left ventricular mass index indexed to height to power 2.7. And there are two thresholds for boys and for girls. And starting from 16 years, the definition of left ventricular hypertrophy is the same as for adults. And you can use two different thresholds regarding on the way of indexing of left ventricular mass index. Next one, please. So how to assess left ventricular hypertrophy? Echocardiography is a recommended method. It will show both structure and remodeling. So we can calculate left ventricular mass index and relative wall thickness, what allows to analyze left ventricular geometry. One can also measure left atrial size, which is another marker of hypertension-mediated organ damage in case of severe hypertension. And the other markers of left ventricular damage is the assessment of diastolic and systolic function. As already mentioned, electrocardiography is not recommended as a tool to assess left ventricular hypertrophy. However, it is useful to diagnose arrhythmias, especially in athletes, and it's important because one of the most important drugs in antihypertensive treatment is physical activity. So it is still quite useful tool in general assessment of hypertensive child. Next one, please. Here you see principles of assessment of large arteries. On carotid arteries, intima media thickness is measured. We have referential values both for boys and girls, starting from 6 years of age. And in contrast to adults, we assess carotid intima media thickness only on carotid artery, not at the bulb or internal carotid artery. So we assess arteriosclerosis, but not atherosclerosis. The other tool to assess arterial injury and to assess arterial stiffness is measurement of pulsar velocity between carotid artery and femoral artery. Next one, please. And going to microcirculation, we can assess signs of breaking of the microcirculation barrier, which can be found in hypertensive emergencies. We can also assess remodeling of microcirculation and arteriolar rarification. Next, please. Most often used is classic ophthalmoscopy. It's used for almost 100 years. However, recent guidelines do not recommend this test as an obligatory at first diagnostic step. But it is important to keep in mind that it is very useful in case of severe hypertension. It is in hypertensive urgency and emergency. The other techniques not used in clinic but in research is fundus camera and angio-optic coherent tomography. Next, please. So to conclude, assessment of hypertension-mediated organ damage is an essential and very important step in diagnostic approach to hypertensive child and adolescent. The most important marker of hypertensive organ damage is left ventricular hypertrophy and its dysfunction. The presence of target organ damage is an indication to extend the diagnostics and to start pharmacological treatment, as it was shown in the lecture of Professor Mancia. Even patients with quite low blood pressure, but with markers of hypertension-mediated organ damage will have increased cardiovascular risk. Assessment of arterial structure, what means assessment of carotid intima-media thickness, is also indicated if possible, but not obligatory. The remaining markers of hypertension-mediated organ damage have their interpretation limitations in pediatric patients. And next one, please. Thank you for your attention.
Thank you, Mietek, for your very nice presentation and for all the hard work you have performed. Now it is my pleasure to invite Professor Małgorzata Wójcik for her presentation on lifestyle modifications. Professor Małgorzata Wójcik is a professor in Jagiellonian University in Krakow, specialist in pediatrics, endocrinology, and pediatric diabetes. In the field of special interest, a special place is occupied by childhood obesity and its complications, and she is a member of Polish and foreign scientific societies and working groups. Małgorzata?
Thank you very much for this nice invitation, and thank you for inviting me to share my experience with pediatric patients and lifestyle modification as the way to prevent and treat hypertension. Next one, please. And next one. As you all know, the face of pediatric hypertension has been changed. In the past, it was the problem associated with underlying conditions, and nowadays, every year, every month, we observe more and more patients with primary hypertension. Is it really primary? According to our knowledge, most of the cases is associated with increase of pediatric obesity. Next one, please. If we compare the prevalence of hypertension in general population, next one, please, we will see that obesity and overweight are associated with higher risk of elevated blood pressure. In comparison to slim peers, obese patients have significantly higher frequency of hypertension. Next one, please. And what has been seen, next one, even in the paper published more than 10 years ago, rapid increase of the prevalence of primary hypertension associated with increase of obesity. I believe that nowadays the picture is even worse. Next one. The association between blood pressure and body weight seems to be obvious. The more fat tissue we have, the higher blood pressure is observed. Next one, please. But why? The relationship is not only due to body weight, not only due to amount of fat tissue, but the real problem is the hormonal activity of fat tissue. The excess of fat tissue is associated with abnormal function of the hormonal regulation associated with regulation of blood pressure. And look at this example. If we reduce body weight for 5% only, for example, we reduce from 80 kilograms to 76, which means still not spectacular effect, we can observe really excellent effects regarding to the hormonal production, hormonal action, all the systems associated with increase of blood pressure. So the best way of treatment of pediatric hypertension caused by obesity is to reduce fat tissue. How can we do it? Next, please. Obesity is a very complex disease. To treat obesity and to treat arterial hypertension associated with obesity, we have to understand that the problem in obesity is not only high body weight, it's a problem of the metabolic regulation, the problem of storage of abnormal amount of fat tissue. So the areas of intervention are also very complex. There is no one drug, there is no one simple intervention that will lead to a decrease of fat tissue and decrease of hypertension value. Next one, please. So from the studies and from the real life, that lifestyle modification is the best way to improve the health condition of pediatric patients with excessive body weight. But we know that getting them slimmer is not the goal. We have to improve the general condition, the general health, and not only somatic, but also psychosocial function. And the areas of intervention are very complex regarding the family, school, environment, and health conditions. Next, please. Let's focus on three main factors, three main fields for intervention: diet, physical activity, and sleep. Next. We have proofs from the papers, from scientific reports, that intervention focused on diet and physical activity and reduction of sedentary lifestyle may be beneficial for our pediatric patients with high blood pressure due to obesity. I show you some recent papers focused on intervention, short interventions, which significantly reduced blood pressure. The third one is the study from my group, published by Dr. Kozioł-Kozakowska. This was really spectacular. The effects surprised even us. Personally, I must admit that we had some problems with reviewers because the intervention was very simple. Children started from increase of physical activity for 5 minutes a day, and we added 1 minute every week. So it was a very, very little intervention, actually almost nothing. And after 3 months of such little amount, we didn't observe spectacular decrease of BMI or body weight. But what we observed, improvement in metabolic state of those patients, and what was really surprising for us, significant decrease of systolic and diastolic blood pressure value. The longer the intervention is, the bigger the effect, the impact of blood pressure is. What is the weakness of this kind of intervention? Intervention is only the intervention. It starts and it finishes. And now we know that the base for the success in treatment of obesity and prevention of hypertension is to change habits of our patients, not only during the intervention, but during the whole life. Next, please. And it's really difficult. It's difficult regarding to diet, to physical activity, but let's focus on the third, sleep. Sometimes we don't ask about the problem with sleep, our patients, but it's really important. Sleep is important to maintain the balance and the rest. During sleep, not only rest the brain, but also our nervous system sympathetic and parasympathetic may relax. And the recommended values of hours of sleep are printed in the table, are even more than we know from the real life our children sleep. Next one, please. We have nice proofs from scientific reports that lack of sleep or sleep disturbances may lead to increase of cardiovascular risk factors and hypertension, even in children and adolescents. Next. The mechanism is really complex. During the sleep, our balance between sympathetic and parasympathetic nervous system may be reached. If we awake during the sleep or if we go to sleep very late, this balance is not reached. That may lead to higher appetite, to inappropriate secretion of hormones, to inappropriate diurnal rhythm of cortisol, and many, many others. That leads to increase of appetite, increase of snacking and obesity, and as a consequence to increase blood pressure. Next, please. And we have a very nice papers showing the relation between sleep quality and duration and blood pressure. The longer and the better sleep is, the better profile of blood pressure we can reach in children and adolescents. Next, please. And what we know, increasing our sleep duration by 1 hour during weekends, if you don't have time to sleep during week, may reduce the risk of development of hypertension by 17%. And if you increase your sleep time during the night by 15 minutes only, you will reduce your systolic blood pressure by 7 millimeters of mercury, which is approximately 6 times more than reduction of 1 kilogram per square meter of BMI. So if you have an adolescent and it's really difficult to start the intervention to increase physical activity or force them to improve their diet habits, talk about the sleep and advise them to sleep appropriate. Maybe it will be the first step to increase their health. Next, please. And the lifestyle interventions for blood pressure reduction has been summarized in this nice paper, which was already mentioned in many lectures today. Authors of this very comprehensive review focused on several fields of lifestyle intervention. Next, please. According to the diet approach, actually nothing new. The best way is the DASH diet, and what is very important, the meals. The meals should intake at least 2 servings a day of dairy products and at least 3 servings per day of fruits and vegetables for adolescents. We avoid sugar sweetened drinks, and what is important, we should also discuss the salt intake for children, because we know that not only sugar but also salt is not good for blood pressure in children. Next, please. Physical activity. What should be underlined? Regularity. The most important is daily physical activity. Daily is the most important word. The kind of physical activity is not so important, but the regularity really matters. And the more you are active, the less you sit. So we should also avoid sedentary lifestyle. If you don't force your children to increase physical activity, try to explain them to reduce the sedentary hours during the day. Next, please. And what I mentioned, recommendations for sleep. Don't forget about this. It's really important. Short sleep is a risk factor for pediatric hypertension, especially in those who present with overweight or obesity. So try to explain to your patient that the sleep is important, that they should sleep as many hours as is recommended for the age group. And we also don't have to forget about environmental factors like air pollution, like food pollution, and the others. They may also affect the blood pressure in adolescents and cardiovascular risk factors. Next, please. Thank you very much for your attention. And I'm waiting for questions at the end of the session. Thank you very much.
Thank you very much, Małgorzata, for really nice presentation, and which could be also example for the parents as well, not only the children and adolescents, all the lifestyle modifications. Now I would like to invite Professor Elke Wühl for her presentation on pharmacological treatment. Professor Wühl is a Professor of Pediatrics and Consultant Pediatric Nephrologist at the Center of Pediatrics and Adolescent Medicine, University of Heidelberg, Germany. She is certified pediatric nephrologist and hypertension specialist, and her special interest is in childhood hypertension and comorbid complications of chronic kidney disease. And since 2019, she is the executive board member of the German Hypertension League, and since 2020, vice chair of the HyperChildNET European Network for Blood Pressure Research in Children and Adolescents. Elke, please.
Serap, thank you very much for your very kind introduction, but unfortunately, Tomas is first. We changed a little bit the sequence of our talk.
Okay, then I can introduce Professor Seeman also, Tomas.
And then we will just continue. So I will start after Tomas' presentation, but thank you very much.
Thanks to you, Elke. And Tomas, Professor Tomas Seeman is a pediatrician at the Department of Pediatrics, Charles University Prague, postgraduate studying at University of Heidelberg, Germany, and the founder member of the International Pediatric Hypertension Association since 1999, member of the Czech Society of Hypertension, president of the Czech Society for Pediatric Nephrology, council member of the European Society for Pediatric Nephrology. Tomas, please.
So thank you, Sarah, for your kind introduction. And I would like to thank the HyperChildNET organizing to invite me to this important webinar. I received a task to speak about antihypertensive pharmacological treatment, and my information will be based on the recent guidelines from the European Society of Hypertension and the joint statement of the European Academy of Paediatrics. Next slide, please. So I will cover three topics. First of all, when to start the pharmacological treatment in children with hypertension. Second, what is the first line antihypertensive drugs? And third, which child needs combination therapy? Next, please. So when we should start pharmacological treatment in a child with hypertension. This table shows a clear indication for initiation of pharmacological treatment. So we should or must start with, from the beginning, start with pharmacological treatment in children with symptomatic hypertension like headache, dizziness, encephalopathy. Also, in all children with secondary hypertension, mainly in children with renal hypertension. And also, just from the beginning, in all children with hypertension-mediated organ damage like left ventricular hypertrophy. And also in all children with diabetes mellitus type 1 or 2, and also in children who have primary hypertension, treatment, which is refractory to lifestyle modification covered by Małgorzata. So we have, similar to adults, we have 5 basic classes of antihypertensive therapies. ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. Next one. So here in this table, you can see what are the first-line antihypertensive drugs in different conditions. So the most common condition are children with chronic kidney disease, so renal hypertension. There is no doubt there's definitely first-line antihypertensive treatment medications are ACE inhibitors or angiotensin receptor blockers. Why it is so? Next slide, please. Because it has been shown in many adult studies, this is one Italian range study, that ACE inhibitions or ACE inhibitors are renoprotective or better renoprotective in comparison with non-ACE inhibitor antihypertensive treatment medication. So the patients reached end stage. In this case, in this study, the patient reached end-stage renal disease less frequently if they were on antihypertensive, on ACE inhibitors, in this case, ramipril. The latter slide, please. The slide before, so two back. One more back, thank you. The second category, second conditions is are children with diabetes mellitus. Again, here, first-line antihypertensive medications are ACE inhibitors or angiotensin receptor blockers. In patients with coarctation aorta, calcium channel blockers are first-line because they are mainly vasodilators. Another category, children with who have microalbuminuria, again, the first-line therapy are ACE inhibitors and angiotensin receptor blockers because they can lower not only blood pressure, but also albuminuria or proteinuria. Here is the mechanism of nephroprotection of ACE inhibitors or angiotensin receptor blockers. They produce predominant vasodilation of efferent arteriole, therefore they decrease the intraglomerular pressure, so decrease intraglomerular hypertension, which from the long term slowed the progression of chronic kidney disease. Next, please. What about children with, what about the first-line antihypertensive drugs in children with primary hypertension? We have no real data about this. Next, please. So we have two groups of antihypertensive drugs. One are metabolic neutral, like ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers, and drugs that have metabolic adverse effects like hyperlipidemia, hyperglycemia, hyperuricemia. The drugs are beta blockers and diuretics. Next, please. Another factors that will decide which drug we can start in a child with primary hypertension are patient-associated factors like metabolic factors like obesity, diabetes mellitus, or migraine. Factors like lifestyle factors in children who are competitive athletes, or the patient can also have some contraindications to some antihypertensive drugs, like children with asthma. They are relatively contraindicated beta blockers. We have also drug-associated factors then that influence the choice of first-line drug in children with primary hypertension, which are adverse effects of the drugs, as I mentioned. But we have also some positive factors of some drugs, especially some cardioprotective effects of inhibitors of renin, angiotensin, aldosterone system, or beta blockers. Next. So this table shows some situation which some drugs are contraindicated. Like in competitive athletes, it's not good idea to prescribe beta blocker or diuretics. The same for diabetes. And for pregnant children or the adolescent, ACE inhibitors are absolutely contraindicated. Next. So in the case, what is the first-line antihypertensive drugs in primary hypertension. The choice of the drugs is based on both patients and drug factors. So the choice is individual. So we have no one drug fits all approach. This is a statement of Professor Osler, created the first resident teaching program for medical students, who said, the practice of medicine is an art. So we hope to have practice of medicine as a science, but here we have no real evidence. It must be still after nearly 100 years an art. Next, please. And finally, shortly about combination therapy. I think I will skip this because Professor Mancia told about this. Next slide, please. The combination therapy in general in children is indicated in children with severe symptomatic hypertension, so with hypertensive crisis, or at least above 99th percentile or stage 2 hypertension. Or the second group are children who does not achieve with initial monotherapy with maximum recommended and tolerated dose the blood pressure goal. And about the blood pressure goal will speak in next talk Professor Wühl. So next slide. So I would like to conclude and summarize that we have clear indication to start pharmacological treatment in hypertensive children, especially with secondary hypertension. The first-line drugs for renal parenchymal hypertension are ACE inhibitors and angiotensin receptor blockers. First-line drugs for children with primary hypertension are individual, and combination therapy is needed often when blood pressure goal is not achieved, and this will be covered by my colleague Professor Wühl. Thank you for your attention.
Thank you very much, Tomas, for the very nice presentation. And now we can ask Professor Elke Wühl. Elke?
Thank you. So good afternoon. I'm going to continue with the blood pressure targets. And so the decision to start pharmacological antihypertensive treatment in a child should not be based on blood pressure level alone, but it's also based on present symptoms and comorbidities, the etiology and the duration of hypertension, and the presence of hypertension-mediated organ damage. However, this is a kind of disclaimer. These recommendations are not based on randomized controlled trials or mortality studies in pediatrics, but several uncontrolled studies have shown that antihypertensive drug therapy in children is associated with reduction in hypertension-mediated organ damage, such as left ventricular hypertrophy or microalbuminuria. Next, please. So the aim of the pharmacological antihypertensive treatment is first the normalization of blood pressure, but the overarching goal is the prevention or reversal of hypertension-mediated organ damage. And now we have to think about what is the blood pressure level we should aim for. Next, please. So first, as we sometimes do as pediatricians, we have a look at the blood pressure targets for adults. And there are two thresholds, actually. The one, the start of drug treatment is recommended, and that's the threshold that is used for the definition of hypertension, and that's 140 to 90 in adults, as you all know. But the goal for long-going antihypertensive treatment is to lower office blood pressure to 130/80. And on the left side, you can see in green the target range, and in red the range you should avoid, which is below 120 to 70 in adults. So next slide, please. In adults, there are a little bit varying recommendations also for patient age, as Professor Mancia showed, but also for several diseased entities, for example, for chronic kidney disease. And the recommendation, for example, for patients with CKD is to lower blood pressure to below 140/90. But for young children or patients with albuminuria or those with high cardiovascular risk, it's recommended to lower blood pressure below 130/80. And that's also true for kidney transplant patients. But overall, the recommendations for patients with CKD is not to lower blood pressure to less than 120/70. Next slide, please. So what should be the blood pressure target for children? The first one, where we also have the definition for hypertension, is just below the hypertension threshold, which is the 95th percentile in children. And for adolescents, it's varying a little bit over countries and continents. For Europe, it's below 140/90. In adolescents starting at the age of 16 years of age. In the US, it's below 130/80, starting at 13 years of age. And Canada has two thresholds for school children and adolescents. So it's 120/80 for the 6 to 11 years olds and 130/84 for adolescents aged 12 to 17. And this already showed that the thresholds are varying with different countries. So another approach might be to have individualized BP targets for gender and age. That's what we actually have if you look at the patient blood pressure percentiles, but also for underlying disease and comorbidities. Next slide, please. The treatment goal for children and adolescents with primary hypertension, given in the European recommendations for children and adolescents, is to normalize blood pressure to a level below the 95th percentile for age, height, and sex in children and adolescents below 16 years of age, and to below 140/90 in adolescents 16 years or older. Next slide, please. But it's suggested to lower blood pressure to below the 90th percile or to below 130/80, but that's not based on hard research data, but on expert opinion and results of prospective population studies that showed a linear relationship between blood pressure levels starting from 120/80 in adolescents, and higher blood pressure was related to higher risk of increased CIMT and pulse wave velocity in the 4th and 5th decade of life. Next slide, please. So I would now like to show you two examples for patients with special disease conditions. The first one are patients with diabetes. There are no actually proved strategies in juvenile diabetes, but there's experience from adults with diabetes that reinforces the recommendation of aiming at a strict blood pressure goal in children with diabetes. So pharmacological antihypertensive treatment should be started in diabetic children as soon as hypertension is confirmed, which means a blood pressure above the 95th percentile or blood pressure above 140/90. But the goal of treatment should be strict, so it's not suggested to go below the 90th percentile, but recommended. Next slide, please. And as a little bit more evidence for children with chronic kidney disease, we know that hypertension and also proteinuria is associated with a faster progression of chronic kidney disease and a higher risk of kidney replacement therapy. And in the ESCAPE trial, it could be shown that strict blood pressure control attenuates progression of chronic kidney disease, and that this effect correlates with a degree of proteinuria. So the higher the proteinuria, the more effective is to lower blood pressure. In the ESCAPE trial, the blood pressure in the intensified blood pressure control group was reduced to below the 50th percentile compared to the 50th to 95th percentile in a cohort of patients with chronic kidney disease stage of 3 to 5. And the risk for end-stage kidney disease could be reduced by 35%. Next slide, please. So if you look at the lower part of the table, for children with chronic kidney disease, the recommendation has been stratified by proteinuria. It's a blood pressure goal below the 75th percentile is recommended for non-proteinuric CKD and below the 50th percentile in proteinuric CKD. So that's going a little bit below the recommended threshold for adults. The recommendations for adolescents of below 130/80 or below 125/75 in proteinuric adolescents is somewhere in between, but it's now transient is going very smoothly over in the recommendations for the adults with chronic kidney disease, where the recommendation is 120/140 over 70/90. And in young children, a lower range can be preferred with 120/30 over 70/80, or also in proteinuric patient. Next slide, please. So when start a combination therapy to reach blood pressure target? This should be done whenever a single agent prescribed at the maximum recommended or tolerated dose does not achieve target blood pressure. And combination of different drug classes with complementary modes of action should be prescribed, taking into account the underlying diseases and comorbidities of the individual patient. Next slide, please. And that's the step scheme, which is recommended, as Thomas already talked about. And of course, you can go for the highest dose and then increase and add another drug. But you might also consider to improve maybe tolerability of a drug to start a combination therapy a little bit earlier and to have the effect of a kind of a beneficial interaction of the drugs. So if you combine an ACE inhibitor with a diuretic, this might be more effective than going for the highest dose of the ACE inhibitor alone, for example. Next slide, please. So in contrast to the adults, which start with a dual combination therapy in most patients, the recommendation for children is still to start with one drug and then uptitrate. The recommended single pill treatment is not feasible for young children because of the dose restrictions, but might be a good option in adolescents. Next slide, please. And for still elevated blood pressure, despite the combination therapy with 3 drugs, there's also additional drug classes that can be used, for example, steroidal mineralocorticoid receptor antagonists, loop diuretics, alpha-1 blockers, centrally acting agents, or vasodilatators, and for special comorbidities, for example, for chronic kidney disease and diabetes, SGLT2 inhibitors and non-steroidal mineralocorticoid receptor antagonists might be an option in the near future, and there are studies starting. Next slide. So in summary, arterial hypertension is the most important modifiable risk factor for cardiovascular morbidity or mortality, and therefore appropriate antihypertensive therapy, including lifestyle measures and pharmacologic treatment, should be initiated in children and adolescents as soon as the diagnosis of arterial hypertension has been confirmed and the risk factors for hypertension-induced organ damage have been thoroughly evaluated. However, we still need studies to better define blood pressure targets, especially in subclasses of our patients, and to elucidate benefits and safety profiles of single drugs and drug combinations in children and adolescents. Thank you very much.
Thank you very much, Elke, for your excellent presentation and also for the very hard work you have performed as the Vice Chair of HyperChildNet. Now our last speaker will be Professor Manish Sinha, Professor of Pediatric Nephrology at King's College London and full-time clinician working as a consultant pediatric nephrologist at the Erdine London Children's Hospital, UK, part of Guy's and St. Thomas Hospital. His research interests include the study of hypertension in children with and without kidney diseases, with a focus on studying understanding the hemodynamics of hypertension and evaluating its impact on the heart and large arteries. He is the current research secretary for the British Association for Paediatric Nephrology. Now his topic will be suggested schedules for follow-up and examinations. Manish, please.
Thank you, Serap, for the kind introduction, and thank you again for the invitation to participate in this important webinar. I really do value the opportunity to interact with colleagues working in general pediatrics, which is, as I'll show you, one of the issues we have in the management of children with hypertension. So I've been requested to talk about the follow-up schedule of the hypertensive child, and I chose to put that in italics to try and just highlight to me that hopefully when we are thinking of follow-up, this child is not as hypertensive as they were before. And with that in mind, we're thinking about all children with and without kidney diseases. So I'm a pediatric nephrologist by profession, so there's always a unfortunate slant towards nephrology with me. So the frequency of review is dependent upon the underlying etiology, the presence of comorbidities, and the severity of the hypertension target BP level. And obviously in a treated child, this may be different. But as was, next slide, please, as was just highlighted by Elke and Tomas, that there are differences in the BP targets as per etiology. So on this cartoon, I have highlighted the 95th percentile as the threshold for hypertension in children, and then shown on the first column on your left, the 2016 ESH guidelines for type 1 and type 2 diabetics, where the thresholds are below the 90th centile. For primary hypertensives, the thresholds are again similar. And for children who have chronic kidney disease, different clinical practice guidelines across in North America and in Europe highlight differing thresholds, although they do agree that the lower thresholds are relevant and important in children who have chronic kidney disease. I think one other thing I wanted to highlight here is that children who have diabetes and also have got chronic kidney disease, it's important in them to target a lower threshold. And so again, they would be for optimizing blood pressure towards the lower target of 50th centile. Next slide, please. And so when you think of follow-up schedule of the hypertensive child, I've tried to think about it in terms of clinical situation, the management plan, which is the middle column, and the follow-up. And to try and keep it very simple, in the child who's got primary hypertension but has no evidence of hypertension-mediated organ damage, so for example, left ventricular hypertrophy or any complications associated with the primary hypertension, you know, our first line always is non-pharmacological lifestyle modification. And in these children, you know, infrequent but important to have regular reviews, and they don't necessarily always need to be in a medical setup, and certainly ideally not relevant to bring them to the most difficult parts of the healthcare system, as in tertiary centers. And so the closer they can be near home, the better. Primary hypertension with hypertension-mediated organ damage, where it is symptomatic, we will need combination of pharmacological but also lifestyle modifications, which should always be the focus of our care. And these children definitely need frequent and regular reviews. And these regular will depend on the level of pressure and targets we are aiming. The previous slide, please. In diabetic children, we would again have similar combinations of pharmacological and lifestyle modification, and they too will need frequent and regular, and they often are shared with endocrine teams or diabetes teams and hypertension teams. And then kidney disease, they're usually run by pediatric nephrologists sitting in tertiary centers, but often in the healthcare system where I work, often with in combination collaboration with colleagues in district general hospitals or secondary care. Next slide, please. So telemonitoring is an important thing that has come through now, and increasingly something which we can do. And this is an important point I wanted to highlight via this meta-analysis done in adults. Please just press the button again. Thank you. And perhaps not very clear, but what this meta-analysis data is showing, that on the left, the diagonals which are shown, the rectangles which are shown, if they are on the left-hand side of the line in the middle, then they are showing the beneficial effect. And the further away they are from the line, the better effect they have. And what is visible, can we please press the button again, please, is that starting from the top, if you were to just request your, and these are all adult data, starting from the top, if you were just to get your adult patient to monitor their blood pressure at home and provided no support, the impact is not really very good. But with increasing support, as shown by web or phone feedback, or with education added to it, or with telecounseling added to it, which is the last group of studies, you have the most beneficial effect. And although there are very few, if any, data for children using telemonitoring, I think this is a really helpful thing for us to remember, that whenever we are suggesting home blood pressure monitoring and telemonitoring in the various ways it is possible now, apart from instrumentation knowledge, it's really important to support them with education and counseling. Next slide, please. And it is important to remember with children that although it is good to have home blood pressure monitoring, it is relevant, and it's important not to miss masked hypertension, which is the phenomenon of having a normal office BP or even home BP, but not having very high or abnormal elevated ambulatory blood pressures. Please press the button. I've got and it's just really highlighting the masked hypertension effect which you see, and this is, again, click please, and that is seen more commonly in children who have diabetes and those who have chronic kidney disease, and almost twice that to children who have primary hypertension. Next click please. And therefore annual assessments is important in these group of patients with a 24-hour ambulatory study. Next slide, please. What is also important in terms of when we are thinking of the follow-up schedule and the examinations is the relevance to look for the hypertension-mediated organ damage. And for most things, this is looking at for left ventricular hypertrophy. Next slide, please. And also looking at the retinal vessels in terms of small vessels. So the echocardiography suggestion, as per our recent document from the HyperChildNET group, is to show that if you have well-controlled hypertension and no hypertension-mediated organ damage, it is still important to review this every so often, and perhaps once every couple of years. But if there is LVH, it is important to do that more regularly. Please press the button a couple of times, please. And this is really relevant because you can, press it again, you can see de novo LVH. And that's part of the reason to go back and review it in a couple of years' time in those who have even controlled hypertension. Next slide, please. So all these are resource-heavy suggestions, and therefore it's really important to try and remember that a lot of these suggestions will depend on the resource available and the healthcare systems we work in. And I've just really shown you here our unpublished sort of protocol for managing our own CKD patients in my center, where if you're trying to get the blood pressure below the 90th centile, shown on the right-hand side of your screen, we would use a combination of ambulatory blood pressures, assisted standardized office BP, and echocardiogram, and use that more frequently until we achieve better control, as shown on the left-hand side. And in those patients who have a high risk, which is, if you press the button again, please, we have defined as children who are needing more than one antihypertensive, those who have low GFRs or LVH, we would perform more frequent ambulatory blood pressure studies. But just really to be able to use our resources appropriately, we would use ambulatory blood pressures less frequently in those who have got got blood pressures already sitting near the 50th centile. Press the button again, please. And in the middle are a group of patients who have suboptimal blood pressures, which we would use a combination of things, but in effect do more frequent monitoring. So I really just wanted to, the details of that was not important. What I was really wanting to highlight is that some complex patients like children with chronic kidney disease and diabetes with kidney disease can often be looked after in tertiary care, but a number of aspects of their care needs collaborative care with our colleagues in general pediatrics, and standardizing our method of measuring blood pressure, but also understanding the reasons for doing that remain very relevant. And that's why these interactions like today are so helpful. Next slide, please. So the frequency of review is also dependent on the patient's knowledge and understanding. And we all have met families where we feel that some additional support is necessary. And in some families where we feel comfortable in leaving them for want of a better word, to their own devices for longer. And these are really important. And I think, recent reviews have suggested that we regularly forget to educate our patients very well about both the importance of the management of hypertension, but also its relevance to it. And as a clinician, for me, one of the other things which is very relevant is making sure that the growing child understands why they are attending hospital appointments, because quite obviously, as they get through adolescence and puberty, they are different individuals to what they were when they were young children, when they might have presented with hypertension initially. Next slide, please. So optimal BP control over time can result in a reduction in both the number and dose of antihypertensives, and is particularly efficacious if it is supported by healthy lifestyle changes. As we all know as clinicians, these are very difficult to maintain, and these remains challenging. And within that document, which I referenced before, there are a number of very useful paragraphs and tables about how that could be maintained and education can be done. Reduction of pharmacological therapy is always gradual, but with also regular monitoring, particularly to detect re-emergence of hypertension. Next slide, please. And really, what is really important is for us to remember where we work. And this is just giving you an example for me in the UK. This was on the left-hand side, a paper highlighting the unmet needs in measurement of blood pressure in primary care, where almost 80% of the general practitioner services did not have children's blood pressure cuffs available, leave alone instruments. And on the right-hand side, just really giving you a drill down of what happens for children who present with high blood pressure for us in the UK even now. They have high blood pressure, repeat measurements are performed, they're referred. Out-of-office monitoring in the form of 24-hour is usually performed by a tertiary center. And if hypertension is diagnosed, target organ assessment is also done by usually kidney services for us. And the treatments are also commence. And what we are really getting better and better at, next point please, is that we are getting more and more follow-up by colleagues in general pediatrics in collaboration, working together with tertiary specialists sitting in tertiary centers. Next slide, please, which is my final slide. So in conclusion, there are ongoing deficiencies in our ability to provide hypertension care for children and young people along the lines of what I've talked about. And there is a need to improve our methods to measure blood pressure, and particular focus to evaluate the utility of home blood pressure monitoring, because that is what is most acceptable to our patients. And improving education of patients and parents regarding hypertension management in follow-up care is really very relevant. Thank you.
Thank you very much.
The BP calculator, sorry, just to highlight, is really important. I think it's a very, very useful thing. Thank you. Sorry, Serap.
No problem. Thank you very much for your excellent presentation, Manish. Now we have time for questions. I would like to start asking Professor Wühl. Now we have concluded with the BP calculators, and in most of the pediatric clinics, unfortunately, blood pressure measurement is not performed. Maybe you could comment, Elke, on BP calculators of the HyperChildNet project.
Yeah, so we hope that by providing a very valuable tool for the calculation or visualization of the thresholds just by inserting the measured blood pressure into the computer and calculations on the website to encourage our colleagues really to measure blood pressure, but also to estimate whether the blood pressure values are within the normal range, because that's really sometimes time consuming to look at the age as tables for blood pressure related to gender, age, and height. So the adults have much less to do when they just have their fixed thresholds of 140/90. And I think the different calculators we provide for office blood pressure, home blood pressure, and for ambulatory blood pressure are very, very valuable for all colleagues.
Thank you, Elke. As far as I can see, there are no questions from the audience, but some comments, wonderful presentations, and they thank to the speakers. I have also one question to Małgorzata. Małgorzata, the internet addiction is becoming much more popular, and you have mentioned in the lifestyle modifications that sedentary lifestyle and diet, and when the children are sitting in front of their computers or dealing with their mobile phones, I think it's a growing problem all around the world, not only in Europe, but all around the world. Would you like to comment on it?
Definitely. Thank you for this question. Thank you for this comment. Definitely, it's a huge problem nowadays. And what I tried to show you, usually adolescents use screens in the evening and at night. And it affects the quality of sleep. Naturally, during adolescence, the diurnal rhythm changes a little bit, and they tend to go to sleep later than, for example, younger children. If we add the screen exposure to that, the diurnal rhythm of, for example, cortisol secretion is completely abnormal, and that affects the blood pressure. Even though they don't get obese, they have a problem with the regulation of blood pressure because they don't have this night dip of the blood pressure. And I think it's addiction. It's a problem, the medical condition, a problem for psychologists, psychiatrists, specialists in this field. But if it's just a habit, we should focus on it. And, you know, we see a chance, even as a HyperChildNet, we try to get to those groups, to adolescents, via our YouTube channel and social media, which are built. And as you know, we discuss about this problem, how to use this chance to get with the information and to focus on the healthy habits. But I think it's really difficult nowadays because we can't stop the storm.
Thank you, Małgorzata. Any questions from the audience or also from our speakers? You can ask questions too. Or any other further comment? Augustina, Manish, Nietek, Tomas? If not, we are over time, so I would like to conclude this webinar. And again, our special thanks go to Professor Empar Lurbe and all the distinguished lecturers, and also to the audience, to our colleagues who are together with us in this afternoon. And this video will be on the HyperChildNet website as well. So I'm sure we will reach more pediatricians, pediatric nephrologists, and pediatric cardiologists, all our colleagues. So thank you again, and look forward to meeting again, not only virtually, but face-to-face in further meetings. Thank you.